Be sure to have your ID, your two devices, and your chargers for your devices. If you decide to use something for scratch, make sure you have your dry erase board, the marker, and you can use a clear sheet protector as well. No paper is allowed. Make sure that you have your area cleared, free of any, resources or anything. Ensure that you go through the practice exam through ExamSoft. Make sure that you check your sections, even though it may appear to be the same class, but make sure your section in ExamSoft actually matches the section that you're actually in. And if you're not, you will need to send a help desk ticket to ExamSoft. So who does what? There's so many people on the healthcare team, but particularly we're talking about the registered nurse and the LPN. So while the RN does a more comprehensive assessment, the LPN does assessments as well, but it's not as comprehensive. So the RN does a comprehensive assessment. They formulate the diagnosis using NANDA, and also the registered nurse can plan, they can implement, carry out orders, and they can evaluate. The LPN can also do an assessment. They collaborate with the RN doing the planning. This is when we're coming up with interventions to do. And also the LPN can also implement interventions. For example, they can carry out the wound care, they can do the finger stick, the blood pressures, administer medications, and so forth. LPNs can also collaborate with the registered nurse during the evaluation phase. And that's where we are determined, we're reporting back our findings. For example, the intervention was to administer a antipyretic, a medication for fever. We have assessed the temperature, the Tylenol or whatever the antipyretic was administered. So we come back and reassess that temperature. We report our findings, and then we determine whether that goal was met or the goal was unmet. Okay. The LPN functions in an independent role in the nursing process by collecting data from a client and implementing interventions. And this is the same information that was on the previous slide. It's just looked at it in a different way. The RN comes up with that nursing diagnosis using NANDA. The LPN and the RN, they collaborate doing that evaluation phase to determine if goal was met or determine if there needs to be a new intervention or that intervention needs to be continued. Before collaborating on that plan of care with the RN and the LPN, must assess the client's understanding first. We want to make sure that that client understands. Do they even know what hypertension is? Do they even realize what that means, that they have a fractured hip? So we want to make sure that we assess that client's understanding first of what their disease process or whatever it is that they have going on. The LPN we reinforce client teaching. We do want to make note of any changes that needed to be done to the plan of care. And we collaborate with that registered nurse during that evaluation phase. Okay. When we're collaborating with that registered nurse, be thinking we need to ensure that they're measurable, realistic, and time specific. What can we do to determine whether or not this temperature has improved or gotten worse? Well, we will recheck the temperature every how many hours. And so that is realistic, and make sure that we have that timepiece added as well. How often do we need to check that temperature? Subjective and objective data. Subjective data comes from the patient, whether or not we call them a client, whether or not we call them the patient. We might even call them the resident, but this is information that we gather from the patient, the subject. And it's what they state. Objective data is the information that we gather for the most part using our sense of sight, hearing, touch, like we're touching that skin warm and dry, that wound appearance, those measurements that we gain from measuring that wound and describing what that wound looks like with our eyesight. And also sometimes that wound might have an odor. We would note that as well, or we would note that wound does not have an odor. When we assess their level of consciousness, that information that they give us, are they oriented to person, place, and so forth? Critical thinking is collecting data. Once we get that data, we want to verify, is this data real or is this some data that's not real? And then we want to arrange that data in an organized way. And what that helps us to do is determine whether or not there's any gaps in the information that we have collected. Then we analyze the data and then we test it out. Okay. So let's look at some examples of critical thinking. Noticing a change in a patient's condition, drop in blood pressure, their mental status. They were alert, or easily aroused, readily responsive, oriented ×4. And now they're hard to arouse, or they're alert, but then they're only oriented to one, who they are, person. And so that is noticing that change in that client's condition. Breakfast, they ate at least 75% of their meal. Lunch, they ate 50%, and then maybe supper, they didn't eat anything. That's the noticing that change in that client's condition. Is it that their appetite? Is it that whatever the food was, the items, were they not to their liking? But noticing that change will help you to be proactive, going ahead and identifying whether or not is something physically going on wrong with that patient is why they're consuming less of the food items, or is it a preference, or is it something else going on that's related to mealtime? Because if we don't, and that client continues to not eat, then what do you think we're going to eventually see? There's going to be a decrease in weight, and a decrease in weight, decrease in the calories. We know those calories, the carbohydrates, the nutrients, the protein, those are needed to keep those bodily functions going. And then so over time, that can lead to a problem. So critical thinking also is questioning a medication order that is unusually high. So we have learned medications, we've learned doses, we've learned, what their use is for, we've learned patient teaching. And so think about all of that as you go through your rights of medication administration, as you're looking at that medication. What's that usual dose? And then if that's an unusually high dose, we notify the healthcare provider just to verify, to ensure that that is the dose that they actually want to give. Prioritizing patient care is part of critical thinking. Determining, how much care this client needs. Is this client stable? Is this client unstable? Does this client need two persons assistant? Prioritizing that patient care is part of critical thinking. Adapting to unexpected issues, determining that a pain medication is not adequate for a post-op patient. So it's just a fluid process. Critical thinking, we have to always be thinking about what's going on, what should be happening, and comparing it to the norms that we've learned that will assist you in identifying if there's a change in that client's condition. So we have 4 cognitive thinking levels: knowledge, comprehension, application, and analysis. Okay. Knowledge is when we're recalling that information. Understanding is comprehension. Using what we know as application. So let's think back about our skills lab or our simulation lab. We went in and practiced. We learned that skill. We recalled the steps to administering that medication. We recall the steps to inserting that Foley catheter using sterile technique. Then we were able to pass off our skills checkoff. Then we went to clinicals and we were able to apply what we've learned, that skill set that we've learned. So in clinical, in the event that a client, we were able to administer our client's medication, we were able to insert that Foley catheter, we were applying what we know. Then now let's take it a step further. Analysis. We have that client that we're taking care of. And we realize that they have hypertension, diagnosis of hypertension, and may even have diabetes. And we think back about the skill of learning to do a blood glucose or finger stick, even interpreting and recalling what the labs are for hyperglycemia. And so when we go in and assess the clients and we have information that's abnormal or normal, we're able to break down those complex parts. We know this patient has that disease process. Then we know that these organs, this medication, these lab results, all of these things tells us different things about this client. And then we're able to critically think and then respond appropriately. Okay. So the example that we have here also is potassium. So knowledge, we're recalling that a potassium is 3.5 to 5.0. That's that normal value. Comprehension, what does it mean if the client is hypo or hyperkalemic, if that potassium is too high or too low? What do I do with this information? How do I care for this client? And then analysis, how does what I do impact this client overall? So we're thinking about everything pretty much from A to Z when we put it all together for that client. Okay, Tanner's model is taking the knowledge that we have, that experience that we have, and want to include that ethical perspective. Is this something that we can lawfully do as a PN? Is this right or wrong? And then knowing the patient. We mentioned early on about assessing assessing how much that client knows about their diagnosis, assessing and finding out what their cultural beliefs are, assessing and finding out what are their goals for their health outcomes. That is integral in making sure that we provide that best care for our clients. Ethics is a system of standards of moral principles that direct actions as being right or wrong. Ethics is concerned with the way people, either individually or as a group, decide the following. What actions are right or wrong? If one has the right to do something, if one has the duty to do something. Personal versus professional ethics. Remember, professional ethics, our scope of practice says all the things, the tasks that we can lawfully complete. We can, lawfully do those things. But sometimes our personal ethics, the way things that we believe are right or wrong, might bump heads or disagree with our professional ethics. And we would want to talk to our manager about that. That's something that you might want to bring up during the interview as you're looking at the tasks and responsibilities of the nurse in that setting. You want to make sure that you look at that, and that will help you decide, hey, is this the correct setting for you? And if it is, but there are some tasks that you may or may not want to take part in because of your personal ethics, that's a conversation that you will need to have with your manager. So as nurses, we are ethically responsible for being that client's advocate, being accountable for performing all of those tasks. If you are being asked to complete a task that is outside of your scope of practice, it is up to you first to know your scope of practice. And then if you're being asked, even if it's a healthcare provider, a registered nurse, another coworker, you are able to say no because that is not in your scope of practice. Colleague reporting. This is all needed to keep the patient safe. You don't have to know all the facts or confirm whatever it is that you think is going on with your colleague, but most definitely we need to report that to keep that client safe, to keep the public safe. Okay? Non-malfeasance, do no harm. Beneficence, do good. Autonomy, free to choose. Just make sure that client has all of the information that they need so they can make an informed decision. Fidelity, be true. This includes HIPAA, making sure that we have the patient's consent, their permission, even when we're providing information to family members. Remember, a lot of times patients will have visitors at the bedside, and some of those visitors might be their family. So we want to be careful when we go in to make sure that we're not doing anything that's going to break confidentiality. We want to ask those patients, get their permission or their consent to provide information, to do procedures with them at the bedside. Most of the time, we just ask them, the visitors to step out of the room. But if we gain consent permission from the patient, then that's okay. Justice for all, we're treating all our patients fair the same way. Doesn't matter if they have insurance, if they don't have insurance, if they have insurance, but it's not enough. So we just provide the best care for all of our clients. And veracity, truthfulness, we're being truthful and honest with our patients. Beneficent paternalism is used in emergency situations. It is where a decision has been made about a patient. It is the healthcare provider's stand of, I know what's best for you. So a decision has been made, which is opposite of what the healthcare provider has recommended. So the healthcare providers, of course, this is emergency situations only, and they obtain court orders or a permission to present the information to the courts. Does not mean that the courts will side with the healthcare provider, but it is an opportunity for the healthcare provider to present all of their information to someone, and so that a decision is made whether or not the parents, the guardians' wishes will be granted. That's beneficent paternalism. So we have our Nerve State Practice Act. And from that, the facilities that we work in, they're going to create their policies and procedures and their rules and regulations from that. And they should mirror. And so if we're looking for state statutes that apply to a licensed person, we want to go to that state Nurse Practice Act, that facilities or that organization policies and procedures, their rules and regulations, and then look at any professional groups that might be associated with that healthcare professional, and that will guide you. Is it important to know your state, your scope of practice? Because just because a healthcare provider or a colleague asked you to perform a task, you want to make sure that's something that's in your scope, that you should actually be performing it. Because in the event that you perform a task that's not in your scope of practice, that means you're violating that scope of practice. Okay. So the contents of the Nurse Practice Act, it includes functions of the state board, general procedures, licensure process, elements of unprofessional conduct, information related to reasons for suspended or revoked license, impaired professional program, responsibilities, general functions of the licensed nurse, the definition of nursing specific to all the different types of nurses, LPN, RN, advanced practice, standards of nursing conduct, organization approval and administration of nursing programs, and continuing education. That's all in that Nurse Practice Act. Now, the State Board of Nursing, this is a body of people, and what they do, they're developing programs for impaired nurses. They're carrying out disciplinary actions for violators. They are establishing standards for educational programs. They're approving schools of nursing. They are maintaining those lists of active and inactive nurses. If the nurse does something wrong, what are the steps of that disciplinary process? Usually a complaint is filed to the state board. That complaint is reviewed. An investigation is done. You have to collect all the information. During the board proceedings, that's where the nurse has the opportunity to respond. And then usually they may settle. There may be a formal administrative hearing. There may be some discipline programs that the nurse may have to attend. The board action, it could be immediate. If there's an emergency action, that could mean that licenses are being suspended or actually taken away, revoked. Okay. There might be monetary penalties. There might be remediation. So there are two systems in which healthcare facilities will look in to verify whether or not a nurse has a license. So this is called the nurses. This is a data bank. It's a huge file cabinet that has the nurse's name. It has their license number. the date of expiration, and whether or not that nurse has any disciplinary actions. Okay. Then the other data bank is this National Practitioner Data Bank. That is where if a healthcare provider has violations, have committed violations, or have any disciplinary actions, this data bank houses that. Prior to this data bank, this National Practitioner Data Bank being created, a provider could go from place to place and no one would know whether or not they had any disciplinary actions or violations. So now this data bank houses all of that information so that no matter what setting they go to, no matter what state they go to, that information is housed in that data bank and is made available to those facilities. Liability is being responsible for something. Liability in nursing is associated with the civil law. It includes contracts, negligence, intentional, and unintentional torts. So for criminal, that's government versus an individual, felony or misdemeanor charge, crimes such as homicide, larceny, and embezzlement. And then we have civil, that's individual versus individual. And that's infringement on individual rights, monetary compensation, and that's where those intentional torts or those unintentional torts fall up under. An intentional tort is intended to cause harm. It is what it's saying. They intended to cause harm to the client, either through a threat or actual physical harm. An unintentional tort, the nurse did not mean to cause harm to the client, but harm was caused to the client. An example here is I did not mean to hurt the client. It's no defense if you did not use the rights of medication administration, if you did not use the correct procedure when actually inserting a Foley catheter, and so on and so on. Negligence, failure to act with ordinary care and injury is caused to another. 4 elements needed to prove negligence: duty, breach of duty, damages, and proximate cause. Were you assigned this client? So if you were, it was your duty to provide the care that was outlined in their care plan, to carry out those physician's orders. In the event that those things were not done, that was a breach of duty. In the event that the client received damages, injuries, and there is a direct cause between the nurse not performing what that duty was, those interventions that's outlined on the care plan, if there's a direct cause or link between them, then that means that the nurse was negligent. Duty refers to the nurse's responsibility to provide care in an acceptable way. The nurse has a duty based on education, as well as the policies and standards of the place of employment. Breach of duty means that the nurse did not adhere to the nursing standard of care. What was expected of the nurse was not done. Omission or was not done correctly. Commission. An expert nurse witness establishes the standard of care. They will look at the medical record, all of the documentation, and they will look at the facilities, policies, and procedures that Nurse State Practice Act. They will compare what was done versus what should have been done. And hopefully it matches. Everything that should have been done matches what should have been done. What was on that Nurse Standard Practice Act. Those things that we can lawfully do. Damages mean that the client must be able to show that the nurse's negligent act injured him or her in some way. The client must prove actual damage. Okay. What were those injuries? Do we have x-rays? Do we have reports and everything that's supportive data? Proximate cause means that a reasonable cause and effect relationship can be shown between the omission or the commission of the nursing act and the harm of that client. Did the nurse's negligent act cause the injury in question? Malpractice The legal name for professional negligence means negligence by a professional, malpractice. The most common type of negligence in practical nursing relates to action or lack of action, not to what you intended to do. So it's very important that you document everything. You take the time to provide those interventions and that you document what you have done. What is the difference between battery and assault? Battery, to cause physical harm to someone, and assault is an unjustified attempt or threat to touch someone. So there's actual touch or some type of impact involved with battery. Okay. Chemical versus physical restraint. So chemical restraint, a lot, and we have medications here. If a medication is being administered for any reason other than it has been ordered, then it could be listed as a chemical restraint. An example is, for example, the patient in room 201 has Loratab ordered for pain. The nurse decides to administer that Loratab because, for the most part, we know pain medication slows those processes. It blocks those pain receptors. And a lot of times, there's an altered mental status. A person's are sleepy. And so the nurse is administering the medication so the patient could sleep, not because the patient is in pain. So that would be an example of the nurse administering that medication as a chemical restraint, which should not be done because the order specifically says that the patient is getting that medication for pain, not for sleep. A physical restraint, examples of physical restraints or wrist restraints, side rails up on all sides, wrist restraints, vests. These are devices that are used to confine or bind a patient. That's a physical restraint. Okay. Defamation, damage to one's character, can be through slander, which is spoken, or written, which is libel. So what are some examples of libel? Written, sending that email to the editor of a newspaper, posting on social media, that's messages and pictures. So be careful what you're sharing, because if you're making that post, then you're making that post. And if it is damaging to someone's character, then that's an example of libel. It's in writing, making those posts. False accusations on a performance evaluation also. HIPAA, usually facilities have privacy officers. They inform patients of the facility's responsibility for keeping their information private. If a client or patient is no longer in your care, for example, you were taking care of them when the patient was in the emergency room, that patient has been transferred to med-surg, ICU, that patient's care, you have no involvement in that patient's care. So we should not be continue to look in that patient's record. We must get permission to provide their information, even to family members. So make sure we have their consent. When we are disposing of medication cards, anything that has identifiable data on it, we want to make sure we dispose of it properly. Most facilities have those markers, and then they have certain receptacles that you place information in. Okay. Clients have a right to have a copy of their medical records. Each facility determines the conditions, how those records can be reviewed. Some facilities, even there's a fee for the patient, but they have a right to have a copy. The nurse will adhere to the minimum necessary rule to protect clients' privacy. So an example could be that we have a client that needs some type of medical supply, and that company is going to bring the particular medical supply to that client's home. For example, it could be a bed, a concentrator, whatever it is. So what information is needed to be given to that medical supply company? We have to keep in mind, we want to adhere to that minimum necessary rule. So we're only going to provide that client's name, their address, and the payer information. Diagnosis and all of that other information, their lab results, all of that other information is not needed. So at a minimum, we give the client's name, their address, and the payer information. Clients have the right to refuse, and the right to accept. They just have the right to choose what treatment options they want, no matter how good of an intervention or how we think this intervention is best for that client has the right to choose. And we do want to support them in their autonomy. So informed consent, we want to make sure that client has all of the information that they need to make an informed decision so they can get permission either to have or they can refuse it. So for invasive procedures, the client or patient in their first language or in terms that they can understand, they should have the diagnosis or the suspected diagnosis, purpose and description of the treatment, expected outcomes, expected benefits, and also those possible side effects or complications. They have to be made aware of that. They have to also be informed, well, hey, is there a different or another treatment option? Are there any alternatives? And then, of course, the benefits and possible side effects and complications of the alternative treatments also. They need to know the names and qualifications of the people who will perform the procedure, prognosis if treatment is not done, answers to questions clients won't clarify. You may have to call that healthcare provider back and say, hey, patient number 201, they need some more information about, or they need some information clarified. And also an explanation that the client has the right to revoke written permission at any time. The client has consented to surgery. The client's on the gurney. We're putting them in the elevator. We're heading them down. We're taking them down to the OR. The elevator door is closed. The client says, hey, I changed my mind. That client has the right to revoke written permission at any time. We open those doors back and we take them back to their room. They have the right to change their mind. So we have living wills and durable power of attorneys. These are legal documents. The durable medical power of attorney names a person or a proxy to make medical decisions. Now, that living will is a document that has all of those wishes of the client or the patient spelled out. The living will does not specify a person to make healthcare decisions, but a durable medical power of attorney does specify a person, or they call them a proxy. Do not resuscitate order, advance directive based on the Patient Self-Determination Act that gives a physician legal permission to write such an order. So that order this is legal. Those living wills, a DNR order, those things are legal and we abide by those. At a minimum, make sure that you're reviewing the exam reviews, your classroom recordings. If there are any questions about a concept, please send emails or reach out some type of way to your professor.